Emily is a 16-year-old female with spastic quadriplegic cerebral palsy, diagnosed at birth. She experiences fatigue, impaired gait, difficulty with stair climbing, and reduced mobility. A slight left hip subluxation causes pain and disturbs sleep, further limiting activity. She uses a single point stick and wears orthosis and inhibitory casts for support. Emily lives in a two-story home with her family and with her father and siblings and attends school, though fatigue and mobility issues may impact her participation. She takes multiple medications for pain, spasticity, seizures, and sleep. While she hasn't reported mental health issues, her physical limitations and fear of germs may contribute to psychological barriers. The referring GP has requested exercise physiology to improve her balance, endurance, and stair climbing ability. Shared goals include enhancing function, independence, and quality of life through targeted physical interventions. For Emily, with cerebral palsy and comorbidity of OCD, with the specific fear of germs, better known as contamination related OCD, physical activity can serve as both a physical and psychological tool when adapted to meet their specific needs. Structured physical activity and routine can reduce symptoms of anxiety and depression and improve emotional regulation in adolescents with OCD. Contamination fears may act as a barrier to participation, especially in group or shared settings where exposure to germs is high. To address this, programs will prioritize environments and equipment that the client feels are hygienic and safe. Examples such as sanitized, one-on-one gym settings or home-based programs. For Emily, incorporating physical activity in a way that respects her OCD-related fears while gradually increasing tolerance to mildly triggering situations may benefit both exercise adherence and mental health outcomes. Importantly, the physical activity program should be delivered in a trauma-informed autonomy supportive way, allowing Emily to develop confidence and control while reaping the mental health benefits of regular movement. Cerebral palsy is a chronic, non-progressive musculoskeletal condition that occurs at birth. It impacts the white matter of the brain or the motor control center of the brain. Physical activity is significantly impacted in someone with CP, particularly in adolescents with spastic quadriplegic, as it directly impacts motor control, muscular strength, balance, functional mobility, and endurance. Structured physical activity, especially when tailored to the individual's capacity, has been shown to enhance gross motor function, reduce spasticity, and improve their activities of daily living, such as stair climbing and walking. For Emily, who experiences fatigue, impaired gait, and pain due to hip subluxation, low to moderate intensity activities such as supported walking, task-specific strength and endurance training, or balance-focused exercises using assistive equipment can foster neuromuscular control, energy efficiency, and neuroplasticity. These outcomes provide strong foundations for applying behavior change techniques. Therefore, physical activity not only addresses Emily's physical impairments, but also provides clear opportunities to integrate BCTs to support long-term participation. When developing an exercise plan for Emily, clinical decision making must balance the physical demands of her neurocondition, spastic quadriplegic, cerebral palsy, with the psychological considerations related to her comorbid obsessive compulsive disorder and fear of germs. Evidence-based recommendations for CP highlight the need for repetitive task-specific exercises. However, mental health literature supports moderate aerobic and strength-based exercise to reduce OCD symptoms and improve emotional regulation, but requires attention to environmental hygiene and perceived safety. To meet the demands of both, the program will be individualized, low to moderate intensity, functional exercises in a controlled, sanitized setting to address both conditions at the same time. The exercises chosen will be familiar and safe, slowly introducing activities that challenge both her motor skills and OCD related tolerances. When crossovers arise, such as when a neuro rehab task involves contact with shared services that trigger contamination fears, mental health considerations will initially take precedence to maintain trust, autonomy, and engagement. This is because without trust surrounding the environment and understanding OCD related conditions, physical activity cannot begin. However, exposure-based strategies will be slowly introduced and confidence builds, allowing gradual desensitization whilst maintaining rehabilitation progress. When looking at Emily and her client factors of spastic quadriplegic cerebral palsy and contamination-related OCD, producing anxiety, there are several effective behavioral change techniques for physical activity adherence from Michi. When looking at some that are effective for CP, these include goal setting, action planning, self-monitoring, social support, and graded tasks. As can be seen in the paper by Ezel 2019, the BCT of goal setting and self-monitoring were seen to be effective in enhancing physical activity adherence in patients with chronic musculoskeletal conditions. This was seen through a 95% confidence interval and a p-value of greater than 0.01, deeming it statistically significant. Similarly, in the article by Lin et al. 2022, it can be seen that the BCT of action planning was effective in improving physical activity for people with chronic conditions with a 95% confidence interval and a p-value of 0.001. In regard to Emily's contamination related OCD, specifically her fear of germs and her anxiety surrounding that, some behavior change techniques that have been seen to be effective for physical activity adherence include self monitoring, exposure, problem solving, instruction on how to perform the behavior, and action planning. As seen in the article by Kariokai et al. 2017, it showed that self monitoring of behaviors effective when dealing with anxiety with a p-value of 0.001. Similarly, exposure was used and is recommended as OCD treatment. In an article by Fo 2005, exposure-based therapy had strong effects with a p-value of 0.001 on OCD severity reduction. Whilst there is a minimal evidence surrounding BCTs for Emily's mental health condition, by reducing her anxiety, this will help increase her adherence towards physical activity. For Emily, Plan A will use BCTs of goal setting, self monitoring, and action planning. These are identified as the most statistically significant with confidence intervals of 95% and p values of zero point zero 0.01 and zero point zero zero 0.001, respectively. Goal setting will help provide structure and motivation for Emily. Both Emily and I, the EP, will set clear functional goals, such as increasing stair repetitions or walking duration to track progress and build confidence. These goals will be meaningful and achievable, supporting both physical and psychological needs, particularly for Emily with OCD, who benefits from predictability and control. Self monitoring will involve an exercise diary where Emily can tick off completed exercises, RPE, or mood. If Emily is open to it, a wearable tracker can provide real time data like steps and active minutes, offering objective feedback. This will support self efficiency and help identify patterns in fatigue or performance. Action planning will map out when, where, and how exercises will be completed each week, ensuring routines and predictability and manageable. These plans will address Emily's OCD by using disinfected equipment, limiting shared surfaces, and including pre-exercise hygiene routines. This supports Emily, this supports consistency and reduces anxiety. Together, these BCTs form a structured, flexible plan tailored to Emily's cerebral palsy, fatigue, and OCD. Plan B will incorporate BCTs of exposure, instruction on how to perform the behavior, and problem solving. Exposure will be used to gradually reduce the client's OCD-related fear of germs by slowly introducing exercises in controlled environments. For example, Emily may begin by touching cleaned equipment at home, progressing to short sessions in the clinic where equipment is disinfected in front of her. This graded exposure helps reduce avoidance behaviors and builds tolerance without overwhelming her. Instructions on how to perform the behavior will be provided by myself, the AEP, during each session. This includes step-by-step demonstrations of exercises like sit to stands or stair stepping, ensuring safe movement patterns despite physical limitations from CP. Clear verbal cues and visual models will also be shared through short videos the client can watch at home, reinforcing confidence in their ability to exercise independently. Problem solving will help the client identify and overcome barriers to exercise, such as fatigue, pain, or OCD related triggers. For instance, if anxiety arises around hygiene, Emily and I can work together to establish coping strategies such as using gloves, cleaning routines, or adjusting exercise settings. If fatigue limits participation, sessions can be broken into smaller blocks throughout the day. Together, these BCTs address both physical and psychological challenges by building skills, reducing anxiety, and empowering Emily to engage in regular physical activity safely and consistently. To conclude, Plan A will be used in the next follow-up session to build physical activity adherence for Emily. It is only once Emily has mastered the BCTs from Plan A, or they stop working / aren't preferred by Emily, will we move on to using Plan B. By sitting down together and setting out our goals, Emily track her exercise in a diary and mapping out what actions we will take to perform exercise, I believe this will give her the best chance at adhering to physical activity whilst managing her comorbidities. Here are my references for your resources. Thank you so much for listening, and I look forward to any questions or comments you may have to support me in my work with Emily.